You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is May 6, 2024. Our topic today is Abbas Chapter 14, Specialized Immunity at Epithelial Barriers and in the Immune Privileged Tissues, presented by Dr. Nikita Raje. She is an Associate Professor of Internal Medicine Pediatrics and is the Chief in the Section of Allergy Immunology at Children's Mercy Hospital.
Nothing relevant, learning objectives to expand the understanding of mucosal immunity. So for regional immunity, there are, you think of a few different systems which would be important to have, for which it's important to have regional immunity. So the mucosal immune system is present in GI tract, GU tract, and bronchopulmonary system, as well as the cutaneous immune system, which has some of the properties of the regional immunity. Some of the important parts of that regional immunity are that there is an outer epithelial layer that provides the physical barrier, and then there are underlying connective tissue cells like lymphocytes, dendritic cells, macrophages, and other immune cells. The adaptive immune cells are still present in the draining lymph nodes in that region, and there is an ability to suppress the response to commensals or harmless substances, and that could be anything entering through airway or substances like food that enter the GI tract. And then the regional immunity is important in terms of the different or specialized cells that are present in some of these systems, such as for skin, it could be Langerhans cells, or for GI tract, it's the M cells. Gamma delta T cells are present in the epithelia, and in the mucosa, there are IgA producing B cells and plasma cells. So we'll talk about each of these regions. The most important one that we'll be discussing is the GI tract. And some of the features, as you learn about the GI tract, they're pretty similar with a few differences in the other systems. So let's go over the GI tract in more detail, and then some of the things that we will just point out the differences for the other regions. So in general, for regional immunity as well, what we talked about when we talked and went through all these chapters, chapter 1 to 13, we went through innate immune system as well as adaptive immune system. And so for the regions as well, there are features that belong to innate immune system versus adaptive immune system. So very similar to the systemic immunity, there is a physical barrier, there is a chemical barrier, there are innate immune cells, some proteins like toll-like receptors, and for adaptive immune system, humoral and T-cell mediated immune responses. So, all right. Did I just skip this? Okay, yeah. So the innate immunity in GI tract. So let's think about how that's provided, right? The first one is physical barrier, the epithelial layer that aligns throughout the GI tract has a basement membrane, and there are some tight junctions between these epithelial layer that provide a good physical barrier. But besides that epithelial layer, there is another additional physical barrier in GI tract, which is provided by the mucus layer. And so what's the mucus layer is made of? So the mucus layer is made up of mucins that are secreted by goblet cells. There are different types of mucins, and important one that we know of includes MUC2. So there are MUC2 and MUC1 kind of mucins that are secreted by goblet cells. Now, some of these mucins differ in the regions of the GI tract. In the colonic mucosa, there are two layers, whereas in the small intestine, the mucin layer or the mucus layer is a single layer, and that single layer provides a additional barrier so that the bacteria are in the outer part of the that layer of mucus. So it might get in touch with the tip of the villi that come up, but other than that, they don't get in touch with the intestinal cells. In colonic mucosa, on the other hand, there are two layers of mucin. So the outer layer is colonized by bacteria, but the inner layer is free of bacteria. And so, what do these mucins do? They act as decoy, which means they act like they are part of the intestinal system. So the bacteria might try to bind to them, thinking they'll get access to the GI tract, but then the mucins just get released, right? They can move on, and they can actually they will take the bacteria with them and be released through the stools. So basically, they act as decoy. All right. So also the apical surface of GI tract is coated with membrane-bound mucin, which combine with the various glycolipids to form something called glycocalyx. And that also provides like a thick layer, a physical barrier that's important. So on an average, there's about 6 to 12 liters of mucus that's replaced several liters that are secreted and replaced every 6 to 12 hours. So kind of keeping that in mind, that the mucus layer is there, but it acts as decoy and is kind of replaced every few hours, so that whatever bacteria are in there are not gonna get access to the GI tract. That's the physical barrier that we talked about. Let's talk about the chemical barrier. Chemical barrier is provided by the cells like epithelial cells and Paneth cells. The epithelial layer of cells can release peptides such as defensins, and they have toxic effects because of which they have antibacterial properties. And so again, there are different types of defensins, alpha defensins and beta defensins. Small bowel has more of alpha defensins versus colon has more of beta defensins. So kind of keeping that in mind. And then we talked about the goblet cells producing the mucus and the glycocalyx, and then the Paneth cells also produce some antibacterial peptides. As a part of the innate immune system, there are these cells that are present in the mucosa, such as dendritic cells and macrophages, that can phagocytose and kill the microbes. But now we want to make sure that if they are coming across any microbes, they are not over enthusiastic, and these dendritic cells and macrophages don't cause inflammation. Inflammation in GI tract is pathogenic, and then that would cause problems for us. So it's important that these dendritic cells and macrophages take care of those microbes but don't produce inflammation. They do that because they are more prone to release IL-10 rather than the inflammatory cytokines. These dendritic cells and macrophages also do not have as many toll-like receptors as you would expect them to have in the systemic immune system. There are also innate lymphoid cells, so ILCs, that release IL-17 and IL-22 in the GI tract. So we talked about toll-like receptors and node-like receptors in the systemic immune system. So some of these toll-like receptors or node-like receptors are present in the GI tract, but they are very they are placed in a very tactical fashion, that they come across the microbes that have invaded the immune system. So they are on the basolateral surface rather than on the luminal surface, because here there are commensal microbes, and if there are toll-like receptors, they are going to be always going to be activated because of the microbes that they come across, but those are commensal microbes that don't need to be handled, right? So the toll-like receptors are on the basolateral surface of the intestinal epithelia, and that helps because if microbes are in the lumen and those are commensals, either the mucus layer is going to take care of it, or the IgA that's secreted that's going to take care of it, but there doesn't need to be an inflammatory response from toll-like receptors or not-like receptors that are in the cell. They are going to they are going to be activated because of microbes that are entering the cells, or the toll-like receptors on the basolateral surface. If a microbe has invaded that epithelial barrier, those microbes do need to be recognized. So their PAMPs and NAMPs are going to be recognized by these toll-like receptors. All right, so that was adaptive immune system. The innate immune system. Now we'll talk about the adaptive immune system. So the innate immune system, of course, is made up of T and B cells, but we know that we also want to talk about some of the lymphoid tissues that take part in that immune response. So we know that the gut-associated lymphoid tissue, or GALT, is made up of the regional lymph nodes, like mesenteric lymph nodes, but also there is Peyer's patches that are present in those areas, right? We should, another part of the immune system or lymphoid tissue in the GI tract is Valdeir's ring, that's in the oropharyngeal region, including the tonsils, that provide some of this immunity. We know that the Peyer's patches have a lot of B cells, 5 times more B cells than the T cells that's present in the lymph nodes. Now, some of these, we'll talk about that in a minute for the IgA, how it's produced. But all right, so Peyer's patches, and then we talk about these specialized cells called M cells. So what are these M cells? These are microfold cells. M stands for the microfold, and they are present at the dome of the folds of the intestinal tract. So we'll come back to that and look at what they look like. Now, one of the important features of the adaptive immunity in GI tract is that when there is an immune response from in the GI tract, and there are B and T cells that are activated in the regional lymph nodes, they make effector lymphocytes, right? Like what we know of, if it's helper T cells, they'll make helper T cell subsets. If they are CD8 cytotoxic cells, they'll make CTLs that are effector cells, or B cells will make plasma cells. And the important feature of these cells is that they home to the gut again. So they say they are produced in the regional lymph nodes, such as mesenteric lymph nodes. They can get released into this blood circulation, but they're going to come back to the GI tract itself. And important chemokine receptors and chemokines that take part in that gut homing include CCR9, CCR10. So CCR9 is expressed on the cells that get attracted to the gut because the gut releases CCL25. It also releases CCL28 that attracts cells that express CCR10. So remember, cells that express CCR9, CCR10 are coming back to the gut. Similarly, we know that there is a specific integrin or selectin marker called MEDCAM1 that is gonna make sure that the cells that express alpha 4 beta 7 on them are gonna come back to the gut that expresses MEDCAM1. There are, how is this gut homing possible? It's because of something called retinoic acid that's secreted by the dendritic cells in the gut. So these dendritic cells in the gut express retinaldehyde dehydrogenase that helps in synthesis of retinoic acid from vitamin A. And that retinoic acid is important for expression of gut homing molecules so that the B cells or T cells that are going to be activated, they are going to come back to the gut. All right, so same concepts here. Here's the M cell on the dome of the folds of the GI tract, and underneath that is our Peyer's patch. How does this M cell work? M cell can is able to engulf any kind of bacteria that it can make a pouch around it and transport it to the basolateral surface where it can be taken up by the dendritic cells, or they can be taken up into those Peyer's patches. So that's M cells. We talked about dendritic cells. Dendritic cells can all that are present in the mucosal tissue can actually extend their dendrites or their arms into the lumen, so that they can get a taste of whatever antigen is coming through, and then they can use that to present it to the T cells in the lymphoid tissue. So this is another figure showing the pretty much the whole immune system of the GI tract. So if you look at this, there are these folds that provide the epithelial barrier. There are tight junction between these epithelia. There are these villi that help to move the move any kind of particles that are it's coming across. Then there are M cells that take up any kind of antigen that's coming into the lumen. And then there are these Peyer's patches. There are Paneth cells that are specialized and have antimicrobial peptides. There are all these different cells of the innate immune system, such as dendritic cells and macrophages that are present in the lamina propria of the GI tract. Goblet cells release the mucus layer that it provides that additional physical barrier. And then there are cells such as B cells and plasma cells that are in abundance in the lamina propria. There would be some T cells as well, and then there are these draining lymph nodes that are present close to the intestinal surface. So that's your typical immune system of the GI tract. We know that the vitamin A is taken up by the dendritic cells, converted into retinoic acid, and that retinoic acid acts on some of these lymphocytes so that they are imprinted with the molecules that are needed to home to that tissue. So in this case, coming back to GI tract requires that these cells have CCR9 or CCR10 or MADCAM alpha 4 beta 7 so that they can come back to the gut. All right, so let's talk about humoral. Humoral immunity in GI tract. So we know that there is a lot of IgA that's secreted in the GI tract. There's also some IgG and IgM that's secreted. And it's important to know that the B cells or plasma cells in the GI tract are prone to class switching to IgA. And that's because of presence of TGF beta in that environment. Also, the B cell activating factor APRIL or survival factor APRIL binds to the TACI receptor and helps in class switching to IgA as well. Other factors that help in class switching to IgA include nitric oxide and all-trans retinoic acid. So all the overall environment in the GI tract favors class switching to IgA. We know that the IgA that's made in the GI by the plasma cells and the B cells in the GI tract has to be secreted into the lumen. That's where they perform their function. And so for that, there is a need for this particular receptor called poly-Ig receptor that helps in transportation of IgA across that membrane. So the IgA may be a dimer, right? Typically, a dimer has two molecules of IgA attached to each other by the joining chain, and that joining chain then binds to the poly-Ig receptor that can transport it across the mucosal epithelial cell. So then it's secreted into the lumen. And what does it do in the lumen? It acts as border security. So it's going to just assess who's coming along. Is it a food particle? Is it a microbe? Is it a common cell? And depending on what it is, it's going to make sure that if it's something that's more dangerous, it's going to push it out rather than letting it enter the cells of the GI tract. So it almost works like border security. So transport of IgG, that uses the FC receptor, neonatal receptor FcRn, that can be used, and we talked about the FcRn in another chapter, so hopefully you guys remember that. It uses the pH to make sure that it gets transported across. T cells in the GI tract, there are lots of intraepithelial CD8 cells, so kind of innate immune cells, right? Gamma delta, 10% of these are gamma delta T cells. The lamina propria, though, has CD4 cells. These are cells that produce so Th17 type of cells, so produce IL-17, IL-22. There are some Th2 cells that produce IL-4, IL-13. There are Tregs. Now, interestingly, these Tregs are different from the Tregs that we talked about, we talked about the central or thymic Treg cells, versus the ones in the GI tract are your peripheral or inducible Tregs. These are FOXP3 positive, and the induction of that requires these particular type of dendritic cells aided by retinoic acid and TGF-beta in the environment. Tregs, we know, help in suppressing the inflammatory response. They do that by producing IL-10. Now we know that the IL-10 and IL-10 receptor deficiency can cause early onset inflammatory bowel disease. So important clinical tidbit to remember. So some of the diseases of the GI tract when the immune system doesn't do a good job is inflammatory bowel disease, celiac disease, so autoimmunity, or allergic issues like food allergies. So that's what we wanted to kind of cover in the GI tract. Now, respiratory immune system, again, has a pretty similar regional immunity. So it has innate immune system and adaptive immune system. But instead of having that epithelial layer, the respiratory system has pseudostratified ciliated columnar epithelium that helps in providing that initial physical barrier. There is that chemical barrier provided by some of the proteins, such as some of the proteins that are released that have antibacterial or antimicrobial properties. There are surfactant proteins called collectins. Now, those are like your pattern recognition receptors, right? We talked about GI tract where there are nod-like receptors or toll-like receptors. For respiratory system, one of the important one to remember is the surfactant proteins or collectins that can recognize PAMPs. And there are some innate immune cells such as alveolar macrophages that help in grabbing some of the big molecules or antigens that come along, such as microbes. Adaptive immune system, again, secretory IgA, IgG are important. We talked about they're pretty similar in transportation, they need that poly Ig receptor or FcRn to release them into the lumen. IgE response is possible, right, in the respiratory system because there is a propensity to drive differentiation of the T cells in the respiratory system to Th2 subtype. Genitourinary system, stratified squamous epithelium here. There are lots of dendritic cells, macrophages, Langerhans cells. There are resident B and T cells. Here, most of the antibodies are IgG subtype. Another part of the regional immunity is provided by the cutaneous immune system. Important one because the skin is basically the physical barrier that's provided by the epidermis. And then there are keratinocytes that provide the antimicrobial peptides that provide the chemical barrier. Those can be defensins, cathelicidins, S100. So all these peptides can provide antimicrobial protection. Cells such as dendritic cells there are specialized dendritic cells in the skin called Langerhans cells. They have a protein called or marker called langerine. They have what they are known by structures called Burbeck's granules so those are one type of dendritic cells, so Langerhans cells. There are also dendritic cells that are Langerine negative that are present in the cells. Now remember, in the cutaneous system, T cells that are present, most of either they are intraepithelial, which are the innate T cells, right? Those are CD8 type of cells, maybe gamma delta cells. And then there are most of the cells that are present in the cutaneous system are memory cells. So intraepithelial CD8 cells. In the dermis layer, though, there can be CD8 and CD4 T cells. And again, it's important to remember homing to the skin, because once these cells get activated in the draining lymph nodes, they get imprinted with molecules that help them home to the skin again. And one such homing molecule is called CLA, or cutaneous lymphocyte antigen. So let's see here. Again, this is the skin, epidermis and dermis. Epidermis has mainly the epidermal layer, but also has keratinocytes that provide the chemical barrier. There are these innate T cells called CD8 T cells, and the dermis has various cells like macrophages and dendritic cells. The draining lymph nodes will have the T lymphocytes. They can have CD4 and CD8 cells, right? Now, how does the homing work for the skin? It works through vitamin D. So we talked about GI tract, where homing is from retinoic acid, versus here it comes from, say, sunlight and exposure to or any other exposure to vitamin D, and that vitamin D helps in imprinting those cells in the draining lymph nodes with receptors or molecules that help in homing to the skin. That's CCR4, CCR8, CCR10. They get attracted to the chemokines released by skin, which are CCL17, CCL1, CCL27. So remember, CCL27 is an important one to remember. 25 and 28 are the ones that were in the GI tract that we talked about. Now, apart from that, remember that there are some tissues. So we are talking about regional immunity, and we talked about GI tract and respiratory tract, GU tract. We talked about the skin. And that's really important. But there are some tissues, some regions where immune responses are not as easy to initiate. And that's an important concept for some of these tissues that are called immune privileged tissues, like eye, brain, testes, fetus. And it's important because you don't want any kind of immune response in those regions, because it can actually damage the function, right? So some of the mechanisms by which the immunity is not as readily available in these parts is the endothelial cells in the blood vessels have tight junctions, so it's hard for the cells to enter these tissues. Some of the cytokines that are released from these tissues are immunosuppressive, so they again do not typically produce an inflammatory response. And there are some molecules that are present on these tissues that inactivate and kill the lymphocytes. So something to remember. Now, fetal tissue, of course, is a very specialized has a very specialized system to make sure that there is no immune response, and so there is lack of MHC expression. So T cells should not get activated. There are also Tregs that help to prevent any kind of T cell response. One of the important concept is release of local indolamine dioxygenase, an enzyme that helps in depletion of tryptophan. That helps in preventing immune response as well. So, looking at apart from that, the passive immunity that is passed on to the baby in the uterus is important. So we know in the third trimester, maternal immunoglobulin G is passed on to the fetus, and that happens because of FcRn, neonatal Fc receptor, that's present in the placenta, right? That can take up maternal immunoglobulin and help in transcytosis of that immunoglobulin across the membrane into the fetal circulation. We know that as the gestation progresses, there is increase in the transfer of immunoglobulin in the last trimester, and then that maternal immunoglobulin is present in the infant circulation till about 6 months age. All right, so that's chapter 14.